speaking now to the audience here, the live audience, you can see that we have another picture there. We have two persons who are making all the puzzle complete, actually, for the leadership of the international community of critical thinking, health policy, and scientists and activists, who are David Himmelstein and Steffie Woolhandler, who are our pioneers, especially for their research and the deepening in the United States market system, of course, denouncing the system and giving us, in all over the world, I mean, what is happening and not what will be happened in our world, in Europe, for example, or in Latin America, if we don't oppose these policies. Unfortunately, I remember them both because they are also very long-acting activists in the association, and that they have been in a lot of congresses, even here in Thessaloniki, but even before that, saying always that pay attention, don't follow these policies. Unfortunately, David and Steffie, we are in a very negative position to tell you that unfortunately we are following, not we of course, but our governments in Europe are really the tradition made after the Second World War of state of social care. It's finished in Europe. Actually, now we have all the consortia that's inside privatizing and dismantling the health, or the public health service. So saying that, now I give you, Steffie, the floor to enlighten us and to give us more more evidence of what we have to struggle with. So if you have a document, you share. Thanks.
Hopefully people are seeing my screen. Yes, I think you are. I want to I want to support what's been said previously, that healthcare is really part of capitalist politics, and the deep problems in U.S. healthcare relate to the extent to which the markets and capitalism has been allowed to dominate healthcare. I, like some of the other speakers, came to this from the left. Both David and I, during the Vietnam War, worked very hard to try to stop the Vietnam War. I actually worked for 2 years at a military base in Texas, in South Texas, the largest infantry base in the United States, where the soldiers were organizing to oppose the war and actually eventually refused to fight. So that is in fact the way the Vietnam War ended in the United States. Certainly the brave work of the Vietnamese people, of the anti-war movement, was driving it. But at the end of the day, government was unable to assure that the actual soldiers would fight in Vietnam anymore, and they were forced to end the war completely. So how did I get from being an anti-war activist in Texas, going to jail and being shot at for the opposition to the Vietnam War, to being an expert in healthcare finance? Well, it turns out that the healthcare system in the U.S. is profoundly broken, and there's deep dissatisfaction with healthcare, both among the patients, among the doctors, among the general populace. And there's a giant crack, if you will, in the facade of racial capitalism in the U.S., that people hate the healthcare system. And I'm going to talk a little bit both about that healthcare system, why they hate it, and some of the ways people have organized against it in the U.S. Now, I just want to say I have no financial conflicts of interest. I am co-founder of a group called Physicians for a National Health Program that has been for more than 35 years advocating the decommercialization of U.S. healthcare, has many thousands of physician members and a few non-physician members. I also was an unpaid policy advisor to Senator Bernie Sanders, who ran for president in 2016 and 2020. And I have co-authorships with Senator Elizabeth Warren, who also ran for president last time around. Those are all unpaid positions. So I'm going to talk about the concept of financialization and what that means, and why we say the United States health system is becoming fully financialized. It's a question of who should own care and what is the goal. And the ascending model of financialization is investors are going to own healthcare and their only goal is going to be financial gain. And this is a change from a bygone era where doctors and nonprofit hospitals ran the healthcare system with a variety of goals. I mean, one was patient health, but it was also professional and social norms, the desire to be seen as a good doctor or have a good reputation in the community. And let's be honest about it, doctors in nonprofit hospitals also had financial gain, but it was a mix of motives, not just finances. And we're hoping to build a future in which patients, caregivers, and communities can control healthcare with the goal being population health. So let's talk about the problems in the United States. This is some work we published in the Proceedings of the National Academy of Science, looking at what's happened to U.S. life expectancy. At the top in black, we've graphed life expectancies in other wealthy nations, most of them in Europe, but also Japan and Canada. What you'll see is that from this graph is that life expectancy in the United States began to lag behind that of other developed nations in the 1980s. And then things got very bad during the pandemic when the life expectancy of the United States was 6.3 years shorter than in peer nations. Okay. So, of course, the situation is substantially worse for our racial minorities, particularly Black and Native Americans, who've been particularly oppressed by American racial capitalism. But compared to the average in other developed nations, Black Americans are living 13 years shorter, and Native Americans living nearly 20 years shorter than people in other developed nations. All right. And this is not just diseases of despair that we're all killing ourselves by drinking too much or shooting guns. In fact, the healthcare system has been malfunctioning. This is looking at control of blood pressure, which the doctors in the room all know that this is incredibly important for the population health. And yet control of blood pressure after improving for many decades has started to deteriorate in the United States. We also have a situation where 1/5 of Americans are uninsured at some time over a 3-year period. And it's extremely elderly people because so many of them are covered by a federal program, don't have this problem, but it's primarily a problem of non-elderly adults, where 27% were uninsured at some point in the last 3 years. In addition to this very poor performance in terms of outcomes, the U.S. has very poor performance in terms of costs, with our costs also diverging from the pattern in other nations in about 1980. Now, I just want to remind people what 1980 was. That was the election of Ronald Reagan, which signaled the beginning of the neoliberal era in the United States around 1980. Okay. So currently in the United States, we're spending massive amounts of money on healthcare and getting very little. What I've done in this graph is graph total spending, public and private, at the top in blue for various countries. For the US, I've divided that spending into tax-supported spending in yellow, and then private spending in red. And already tax-supported spending in the United States exceeds total spending, both public and private, in other nations in the world on a per capita basis. And then, of course, we turn around and take another $4,000 out of private pockets just to pay for healthcare in this country. What is all this money buying? It's certainly not buying more physician care. It's not buying more hospital inpatient days. U.S. Americans spend much less days in the hospital than people in other nations. They go home quicker and sicker. What we are getting is tremendous spending on insurance overhead, the bureaucracy, the profit-making bureaucracy of the health insurance companies. And consequently, when we graph the growth of health administrators against the growth of physicians, as I've done in this slide, we've seen a tremendous growth in healthcare managers, thousands of percentage points in growth versus relatively slow growth in the number of actual providers of care like physicians. What we're talking about is something that the late great David Graeber described as bullshit jobs. The growth within healthcare of jobs are so pointless or even pernicious that even the person doing the job secretly believes that it shouldn't exist. Real jobs, like being a doctor or a nurse, produce positive social value, whereas bullshit jobs, like administering payment, produce mere market value. So we've shifted the healthcare system from a system based on social values to those based on just market values. So I want to talk a little bit about privatization of public programs. We say we have private insurers in the United States. In fact, private insurers dominate health policy in the US, and yet they're getting 61% of their total revenue from government payers. That's because the federal government has a privatized Medicare program where the taxpayers pay the entire cost of an insurance premium for elderly people and just turn that over to a private insurance company to actually administer the care. This is increasingly happening within the Medicaid program, the smaller, it's a different program that covers some of America's poor. The government also pays a lot of money for the health benefits of public workers. I now work for the City University of New York, which is a state agency, and benefits at that university are paid by the taxpayers, obviously. So the so-called private insurance industry is getting only about a third of its revenues from private payers. The rest is government handing over money to them. And this is an extremely, and this is what we've seen is a growth in these Medicare, what I call Medicare HMOs, some people call them Medicare Advantage, but these are privatized plans. Government pays virtually 100% of the premium, and they take care of folks over the age of 65 enrolled in the Medicare program, federal Medicare program. It's going up and up and up. Why is enrollment in these private plans going up? Well, it's not because they're efficient. In this very careful study looking at the costs of providing private care and the so-called Medicare Advantage program for seniors versus just traditional Medicare, where the government collects the taxes and pays the doctors and hospitals. In fact, Medicare Advantage is costing more to the taxpayers, and this is 2010 dollars, more to the taxpayers than traditional Medicare, despite the fact that Medicare Advantage is providing less payments for doctors, hospitals, and medications in blue, but they're spending so much money on their overhead, pushing papers around, pushing the money around, deciding who gets the money. Okay, the overhead and profit per enrollee of private insurers is in fact enormous, and just shown some per enrollee figures for employment-related private insurance, which many people have in the U.S., the so-called privatized Medicaid managed care plans, the privatized Medicare plans for the elderly, tremendous amount of money going for overhead that is not being spent in traditional Medicare. So Medicare Advantage, the privatized program for seniors, had overhead in 2019 to 2021 of almost $2,000 per enrollee, just paper pushing costs versus about $200 in traditional Medicare. Consequently, this is some work we're working on now. Medicare has paid private plans about $500 billion more than enrollees would have cost in traditional Medicare. And essentially all of that additional spending has just gone right into the overhead of the private plans. It does not create extra care, extra benefits for seniors enrolled. Okay. We've also seen the provider sector itself, the delivery sector, becoming increasingly for-profit. This is looking at hospice agencies, care of the dying agencies in the United States, which are now at least 75% for-profit. But if we look at all types of delivery organizations, with the important exception of general hospitals, but all other types of the delivery sector, specialty hospitals, nursing homes, dialysis, is increasingly for-profit in this country. One new kid on the block, a new development, is the entry of private equity into healthcare. And for those of you who are not familiar with private equity, most corporations sell stock on public markets. Those are called publicly traded corporations. But private equity does not sell stock. It can be one giant billionaire who's doing it, but more frequently, they collect money from institutional investors. It's quite private. In fact, we don't have good mechanisms for even monitoring their behavior, though we've started to do a little bit of disclosure rules recently. But they can swoop in and come to dominate healthcare without with the public having very little ability to see what's going on. Okay. So private equity strategy in healthcare is that they go and they buy an entity, such as a hospital or a doctor's practice, using debt that's transferred onto the books of the acquired entity, like the hospital or doctor's practice, burdening it with interest costs. And this is also called a leveraged buyout. That's the older term for private equity. Okay. Then the firm squeezes out short-term profits, for instance, by selling off the buildings, cutting the staff. And then they seek to enhance the profitability and asset value so they can sell it at the end by rolling up multiple acquired entities into chains, like chains of doctors' practices, chains of hospitals that have enhanced market power to command higher fees from payers. And the strategy, private equity almost always sells off the hospitals, doctor's office, or other entities within 3 to 7 years. So it's a particularly rapacious and aggressive form of capitalist involvement, for-profit involvement in the society, but also the healthcare system. So we've seen a tremendous number of private equity healthcare takeovers really rising in recent years. And these have been quite harmful. When there's a large private equity investment in our nursing home sector, and these authors, through tremendous effort, were actually able to put together the data to assess what happened when a private equity firm bought a nursing home. First of all, the patients at the nursing home saw their mortality rise 10%. There was much greater use of antipsychotic medications, which we're supposed to avoid in elderly patients. There was a fall in staffing, particularly as nursing staffing, and the actual cost to the taxpayers rose 11% as private equity figured out ways to game the payment system and get more money out of Medicaid or Medicare. Currently, private equity is holding massive numbers of provider organizations, 1,300 women's health practices, 8% of all hospices, 8% of all dermatologists that practicing in the United States, 7% of gastroenterologists, 10% of medical oncologists, 15% of radiation oncologists, over 1,800 anesthesiologists, 4% of hospitals, 11% of nursing homes. And one firm actually controls 25,000 emergency room doctors and other practitioners. So they're going in, they're buying entities, they're rolling them up into these big groups with the idea that they're going to make a quick profit and then sell. Currently, MSA is a metropolitan statistical area. It's a city and the surrounding suburbs. It's just a term used by the U.S. Census. But the number of major cities and surrounding areas where a single private equity firm controls greater than 30% of physicians in a specialty is growing and growing and growing, particularly in the fields of gastroenterology, dermatology, and women's health. So we're facing a for-profit provider, not just the insurance company, but a for-profit provider. When private equity buys a practice, the prices rise. The taxpayers and the patients end up paying more. In this case, showing some of the same medical fields where private equity has come to dominate. So I want to talk about the emergence of giant corporations. David doesn't like the term, but I call them mega corporations. They're these giant corporations that are too big to fail and too big to jail. And they get tremendous influence over regulators in the federal government and over the entire economy. You're probably familiar with this in some ways, but this is what's going on in the United States. United Healthcare, which is the #5 largest corporation in the entire United States, is the largest insurer in the nation, but they also own a group called Optum Health, is where they purchase healthcare providers. They are the nation's largest employer of physicians with over 70,000 employees among practitioners. They run a consulting analytics firm that has claims data on about more than 2/3 of all Americans' medical claims are in the hands of Optum for them to data mine and figure out how to make much more money primarily. And then they run a giant mail order pharmacy that fills about 1.4 billion fills prescriptions every year. We're seeing a vertical integration, not just the insurance company, but the insurance company buying healthcare providers such as doctors and hospitals, buying analytics firms to figure out how to make the most money, buying pharmacies. So that's a giant mega corporation conglomerate vertically integrated at all levels of healthcare. They are not alone in this. CVS Aetna is actually number 4 on the Fortune 500 list. It's a major insurer. It's a chain of pharmacies and it's a chain of doctors. And their structure right now, they own a giant chain of pharmacies, almost 10,000 bricks and mortar locations, a giant mail order pharmacy, pharmaceutical benefit manager. They own a large health insurance company previously called Aetna Insurance that insures about 25 million people. They run a network of urgent care clinics in the stores, and I just showed you a picture of that, where people can go see a nurse practitioner. And they've just decided to expand. They purchased Oak Street Health, which is a Medicare Advantage focused chain of primary care clinics with 169 clinics. They also just purchased Signify, which is they spent $8 billion on Signify, which is a home care and home visit company. So again, a vertically integrated company that controls the insurance, controls the doctors, controls the home care, controls the pharmacy and the pharmacy prices, number 4 in the Fortune 500 list. So very hard to regulate, and certainly the normal mechanisms of the market, which I'm not a big believer in anyway, but even those normal mechanisms in which the market pushes down prices in some settings are not operating. And they're not the only ones. The giant retailers, including Amazon and Walmart, Amazon is the number 2 on the Fortune 500, are entering big into healthcare, setting up doctor's offices, telemedicine, doctor care, telemedicine attainment of pharmaceuticals, and they and many other large retailers like dollar stores are on a buying spree to acquire actual medical providers and set up clinics. Right. Now, I wish I could tell you that it was only these for-profit corporations that we have to worry about. In fact, our nonprofit hospitals have been misbehaving in a major way. Many of them act like what I call for-profit wannabes. They want to make the money too. They're happy to compete and try to make as much money as possible. And this is actually New York City's largest nonprofit hospital system. It's called Northwell. And during the pandemic, they were suing 250 of their own patients per month for unpaid bills, 250 patients every month. So many U.S. hospitals do, in fact, file suits against patients who are unable to pay their bills, obviously discouraging those people from coming back for care and causing financial difficulties for sick people. Okay. Many of our nonprofit health systems are becoming speculative investors. Kaiser, which is a giant HMO, it's been around since right after World War II, during World War II, has got $35 billion in investments, including in hedge funds and private equities. And many of these other systems, organizations, which are giant names in the United States. Ascension was formerly Catholic System, Mayo Clinic, Mass General Hospital, Brigham, Harvard's premier teaching hospital, Cleveland Clinic. These premier nonprofit medical centers are trying to get in the act to make as much money as possible. And as much as it would be nice as a physician to say, well, I'm just not going to participate, the private practice of medicine is really shrinking in the United States as Virtually all physicians are becoming corporate employees. As of 2022, about half of all physicians worked for hospital corporations, 22% worked for other corporations, only about a quarter were in non-corporate practice. So we have to be thinking about how we get control of these corporations, how we return control of these corporations to communities for population health. So just to summarize, what happens with financialization, the financialization we've seen in the United States under neoliberalism, money becomes the mission. Traditionally, providers like doctors or hospitals invested money in buildings or equipment to produce more medical care. So producing more medical care is what we doctors call our service mission, right? Our mission. Now we have financial entities investing in healthcare to produce more money through profit. Money is the mission, and that's actually a fundamental change and something we need to organize against. It turns out that the majority of Americans still support the idea of nonprofit Medicare for all. This is the most recent poll I could find, but 60% of people polled said, no, we want that Medicare for all thing popularized by folks and Physicians for a National Health Program, but even more so by Bernie Sanders. That's still what we want, and yet the American people can't get that at this point, though we're still working on it. The other thing that we're feeling is that it's no longer going to be enough to just have Medicare for all, that is to decommercialize the insurance sector. We need to decommercialize the actual delivery of care. And we see communities, not corporations, need to own healthcare. And this is David and I writing this article, but also 3 former presidents of Physicians for a National Health Program saying we still support Medicare for all, commercializing our insurance, national health insurance, but we also need to regain control of the doctor's offices, the hospitals, the nursing homes, the hospices in order to improve care. And I'm sorry, there's a little problem with the yellow lines, but this is the famous inverse care law from Julian Tudor Hart, where he said back in 1971, the availability of good medical care tends to vary inversely with the need for it and the population served. This inverse care law operates more completely where medical care is more exposed to market forces and less so where such exposure is reduced. And what's under the unfortunate yellow line says the market distribution of healthcare is a historically outdated social form. And any return to it would further exaggerate the maldistribution of medical resources. And of course, the market form in the United States has woefully maldistributed our vast healthcare resources, ending up with much lower life expectancy, much worse outcomes than other developed nations and what you would expect with that kind of expenditure. And that's it. I don't know if we have time for questions or if we're at our time limit.